So since all of us have been doing this for some time, just to look back and reflect, what would you each say was probably in the past 10 years or so, what would you say is the biggest breakthrough that we've seen in AML treatment? Or AML management, I guess is a better way to put it. We'll broaden that.
Yeah, I mean, I think it's two things, and it's venetoclax and targeted therapy. So if I had to say today, the change in outcomes in AML, whether it's for older, well, more for younger, but even for older, it's been FLT3 inhibitors, right? And in the younger, if we look at data from 2002 and 3 with FLT3 ITD mutated frontline patients intensive chemo, many groups showed 20 to 25% was the 5-year survival. And today in the recent studies, if you look at Quantum First and other data sets, we're looking at 60%, potentially higher in below 60-year young fit patient population. That may even get better with the use of more transplant and maintenance and molecular MRD to guide who may need maintenance, who don't. So I think that's been a big step in the younger. In the older, I think venetoclax undoubtedly has had the singular most impactful change. And I think and I think we have to be careful because even though HMA-VEN is good, I think sometimes it becomes a crutch where people believe that it's better than it really is. It's good, no doubt, right? We went from 8% long-term 3-year survival to 24%, but it's not really where we want to be in the end. So I think it's a good backbone, and it's brought a lot of optimism, and a lot of companies who were afraid of going into older AML are now interested. So I think we will see more and more momentum, and that's because of the incorporation of HMA-VEN. And there are, of course, other things, maintenance, gemtuzumab, that have CPX that have added, but I think the targeted therapies in the VEN and the combinations of those so far have really impacted the field.
Yeah, I agree. And now the incorporation of NGS and how we do it from a diagnostic perspective and getting NGS quickly. Like at our institution, we can get NGS within 5 to 7 days. So now we don't treat anymore until we have full information. I think that's a major change than it was previously when everyone just got the same 7+3, regardless of what mutations they had, and that has drastically changed in recent years, and that's what made the development of these targeted therapies feasible and helped us to guide therapies moving forward.
Yeah, I think you guys brought up the top two that I was thinking about as well, which is both the targeted therapies and the way that we can better diagnose the disease. I had to come up with a third one just because I knew you two were going first. And the one thing that I think has made changes, especially in the past 10 to 15 years, I think that the supportive care that we provide now is much improved. Things like the antifungals that we have now compared to just being able to use something like amphotericin when we all first started out really provides a tremendous improvement. I think it also shows the importance for people that have AML to really be seen at a center that excels and that specializes in AML, because it's not just the AML leukemia specialists, it's also the specialists that we see with infectious disease and the specialists that we see in oral medicine and dermatology. These are all things that you really need that level of expertise from a total tertiary care center that really help to best enhance the outcomes for the patients.
I'll make one more point. I think we don't think about it as much because we treat the leukemia and we don't do the transplant. But I think there's been a lot of progress in transplant and outcomes. So, 10, even 5 years ago, most people would say we won't transplant above 65, selective 65 to 70. And today, I think most of our centers are routinely 70 is kind of totally acceptable, and even 70, 75, many are being considered. And I think a lot of that is because they have better GVHD medicine, they have better antifungals, better antivirals, better immunosuppression. So I think there's a lot of progress there, which is impacting a lot of our survival curves as well. And I think we have to give some credit to the transplant field as well, making progress, yeah.
Especially the haploidenticals now.
And the use of haplotransplants, yeah. So, yeah.